Hi, this is Judy Lopry, and this lecture is The Child with Gastrointestinal Dysfunction and Reflux in Adults and Children. Falls under the concepts of elimination and nutrition. And this is for NUR-PNR 180. The objectives of this particular lecture are to identify disorders of motility. In particular, we'll talk about Hirschsprung's and GER. To describe structural defects. We will talk specifically in this lecture about cleft lip and cleft palate. Identify obstructive disorders. For this lecture, we will talk about hypertrophic pyloric stenosis and intussusception, and to describe malabsorption syndromes, in particular celiac disease. The general clinical manifestations of a baby or a child who is suffering from GI or elimination dysfunction is failure to thrive, spitting up or regurgitation, nausea, vomiting, diarrhea, and constipation, abdominal pain, distension, GI bleeding, dysphagia, hypoactive, hyperactive, or absent bowel sounds, and fever. So disorders of motility. We're going to be talking specifically about Hirschsprung's disease, also known as congenital aganglionic megacolon, and gastroesophageal reflux, or also known as GER or GERD. Let's talk about Hirschsprung's disease. As mentioned in the previous slide, it is also called congenital aganglionic megacolon. It is a mechanical obstruction from inadequate motility of the intestines. It occurs in about 1 in 5,000 live births. It is more common in males and with those children with Down syndrome. It basically is the absence of ganglion cells in a certain portion of the colon. So here is a picture of someone who has Hirschsprung's disease. This is the aganglionic portion of the colon, the portion of the colon that is missing the ganglion, where peristalsis does not occur. So because it doesn't occur, it's not pushing the contents out. So it basically causes an obstruction here, causing accumulation of waste products above that ganglionic area. The clinical manifestations is an accumulation of stool with distension above the aganglionic portion of the colon. There is failure of the internal sphincter to relax, internal anal sphincter, and enterocolitis may occur with patients who have Hirschsprung's disease. How is it diagnosed? X-ray, barium enema, anorectal manometric examination. They also will confirm the diagnosis with a biopsy, and what they'll see in the biopsy is the absence of ganglion cells. How do we treat? Well, Hirschsprung's disease the treatment is determined by the doctor, and it's based on how much of the intestines are affected by the disease. Because with Hirschsprung's, there can be a small portion, typically in the sigmoid area or rectal area, you'll see that where the aganglionic cells occur. But it can occur in different sites of the colon, and it also can occur in larger amounts of the colon. There have been cases where the entire colon is affected by aganglionic cells. They also take into consideration the child's age, overall health, and medical history, because many times children with Hirschsprung's disease have coexisting issues that may not make them healthy enough for surgery. How well the child can handle certain drugs, procedures, or therapies, and the expected outcome of the disease. So therapeutic management of Hirschsprung's disease, usually it can be done by a minimally invasive pull-through procedure done by laparoscope. Here's a video when you have a chance. Take a look at it. It describes the procedure. It can be done in other types of surgery as well, and oftentimes it's done in a 2-stage where they'll perform a temporary ostomy, and then the second stage further on, after a little bit of time, they'll do a pull-through procedure. The next topic we're going to be talking about is gastroesophageal reflux. That is basically the transfer of stomach contents into the esophagus. It most frequently occurs after meals and at night. It is very common in infants. GER becomes a disease, GERD, when complications arise, such as failure to thrive, bleeding, or dysphagia develops. What are the symptoms? The symptoms of GER are heartburn and dyspepsia. They are frequent complaints in older children and adults, and non-cardiac chest pain often reported in older adults. There's nocturnal coughing or asthma may occur, and recurrent pneumonia is also a possible symptom. What are the causes? It is primarily caused by inappropriate relaxation of the lower esophageal sphincter. It may be related to increased abdominal pressure from overeating, coughing, sneezing. It also sometimes people with hiatal hernias will suffer from GER. It can be caused by neurological impairment, scoliosis, and obesity has also been known to exacerbate or cause GER. So here's what it looks like with someone with GER. Well, here's a normal stomach right here. And you'll see the lower esophageal sphincter, which occurs right here, is closed in someone who does not suffer from GER. And the stomach contents remain in the stomach and get digested and pass through the duodenum, and digestion occurs. With someone with GER, the lower esophageal sphincter relaxes. So when the person is lying flat, or the flow of the gastric secretions can flow back into the esophagus, causing irritation and eventually erosion of the esophageal area. How do we diagnose? They do a history and physical, upper GI series. They may do pH monitoring, endoscopy, and scintigraphy. How do we treat? Basically, you want to avoid foods that might exacerbate symptoms. You want to eat small, frequent meals. Stop smoking if you smoke. Thicken liquid feedings. Position upright after meals. And surgery is done, but it's usually done for patients who have complications from GERD. The medications that they use to treat GERD: antacids, which neutralize stomach acidity and relieves heartburn, which you all have probably seen, Tums, or taken. Tums or Rolaids are an example of an antacid. H2 receptor agonists, example would be ranitidine, cimetidine, and famotidine, and they work by blocking the amount of acid produced by the stomach. Also, protein pump inhibitors, PPIs, an example of those would be omeprazole and pantoprazole. And protein pump inhibitors are drugs whose main action is a pronounced and long-acting reduction in gastric production. And these drugs are the most potent inhibitors of gastric secretions available. They have a different mode of action to decrease the acid production than the H2 receptor antagonists. They also will use prokinetic medications or drugs. This remains controversial, but they still are used, and the most common one that's used is called metoclopramide or Reglan. And basically that particular type of medication, a prokinetic drug, it stimulates gastric emptying, increasing bowel motility. Therefore, in theory, if it is increasing, stimulating the bowel's movements, then you have less of a chance of the material in the stomach to re-enter into the esophagus. The next topics we're going to be discussing are structural defects. The structural defects we're going to be talking about right now is cleft lip and cleft palate. A cleft lip and cleft palate are facial malformations that occur during embryonic development. They can occur separately or they can occur together. The diagnostic, evaluation, and treatment is multidisciplinary, which means it involves multiple healthcare professionals. So if you look at this picture here, you'll see this person has a little notch in the vermilion, and it's a slight cleft lip here, unilateral. Here it looks like the patient has a complete unilateral cleft lip and probably a cleft palate. Here you will see that the person has bilateral cleft palate and a bilateral cleft lip. And in this particular case, you will also see it looks like this person only has a cleft palate. An example through drawing. Here are the variations that you just saw in the other picture. Here is a slight notch in the vermilion border with no cleft palate. Here is a unilateral cleft lip and a unilateral cleft palate. Here is bilateral cleft lip and bilateral cleft palate. And here is a child who just has a cleft palate. So it is treated by surgical correction, and what's performed first is cleft lip repair. That is also known as a chilioplasty. They close the lip defect, and it always precedes the correction of the palate. What they use is a Z-plasty, and that is used to minimize retraction of the scar. And it's just like it says, it looks like a Z when they are performing reconstructive surgery on the lip area. They will use, after surgery, a Logan bow. This is a Logan bow right here, and that is so that the child and anybody who is near the suture site don't disturb the suture site. They also use, with someone with cleft lip repair, restraints. Elbows restraints, I know that it's frowned upon with many other types of procedures, and restraints aren't typically used, but for someone with a cleft lip repair, they will utilize it because they want to avoid the child from hitting the area and disturbing the sutures. Postoperative care. In infants, they should be in an upright position or in an infant seat to help prevent aspiration. They will do gentle aspiration or oral secretions. They are performed as needed. They do it very gently. It's not with a yank or a suction and roughly managed. They will use pain management. That's important because if the child's crying, they will put pressure on the sutures. Elbow restraints are used to prevent infant from disturbing suture line. If a surgical procedure is done in an older infant, they will use rollover jackets, restraints in addition to the elbow restraints. They will do periodic releasing of the restraints to exercise the arms and to provide parental contact and cuddling. Clear liquid diets are used on the infant until they've recovered from anesthesia. And care of the suture line with cotton tip applicators of saline and antibiotic ointment. The expected outcomes: we want good cosmetic results. We also want them to be able to have normal nutrition. After surgery, we, of course, don't want them to have pain, so we focus on pain relief. And we want the family to be able to manage the child's postoperative care. Surgical correction of a cleft palate, that's called palatoplasty, and that typically occurs 6 to 12 months of age and should be done before speech develops. Throughout their childhood, they may need revisions to help improve speech, and depending on how much of the palate is missing, they may need to augment the palate with a prosthetic. Nursing care or management preoperatively. Well, feeding presents challenges preoperatively. The conventional methods are not possible. Exclusive breastfeeding may not be possible. They will use a modified nipple. If you look right here, here's a modified nipple. The nipple is positioned so it is compressed by the infant's tongue and the existing palate. This would be focusing down towards the esophagus so that the formula would be, or breast milk if you're pumping, would be focused down to the esophagus, avoiding aspiration. Postoperatively, the postoperative site needs to be protected. This includes not putting anything into the mouth, especially after the palate repair. Restraints may be also appropriate. Postoperatively, the child may have packing secured to the palate. That is removed 2 to 3 days post-op. There can be breathing difficulties that occur after surgery, and it usually requires appropriate positioning of the child. Diet after surgery typically consists of the soft and pureed foods. The child is encouraged to drink water to prevent pocketing of food, and the diet is enhanced once the site starts to heal. Intake and output is also recorded. Possible nursing diagnosis. Assessment includes describing the anomaly, eventual surgical site, pain after surgery, the emotional impact of the child's cleft surgery, nutrition and development. And like I said, a multidisciplinary team works to assure child with healthy self-esteem. Long-term care, support and guidance, attention to adequate speech, orthodontics to correct teeth malformation, ears, nose, throat specialist for middle ear issues, and revision of surgical site as the child grows and develops. The next will be on a different tape, so go to part 2 for obstructive disorders.